Okay. So, hi, evening friends, evening everybody. Bache, I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemat-oncology, AIIMS Delhi. So, let us start with our FMG pathology discussion. This is a special session in which we'll be having a look at two things. First is the important topics with respect to the FMG pathology exam. You have to know them, absolutely no doubt about it. I am saying so because the first thing for clearing any paper, for achieving any success, is to know your target. That is the first and the most important thing, which you have to know your target. So let us first have a look at the important points or the important topics that you have to know with respect to pathology, and then gradually we will have a look at the basics of hematology in this session. So firstly, you very well know that pathology is divided into three parts: general pathology, that is the general path; hematology, and systemic pathology. You know this. Now, general pathology, it has five main topics, that is cell injury, inflammation, genetics, immunity, and neoplasia. But irrespective of the paper, that is whether it was a 31st August exam, which was, FMG exam, which was slightly on the different level, or if it was the routine FMG papers, you have around 28 to 30 questions from pathology, out of which 10 to 12 questions are from general path. So general path, or let me even rephrase this as approximately 12 to 14 questions are from general path, which it forms the major chunk of the paper, followed by hematology. Now, the recent trend that we are seeing is you are getting approximately 2 to 3 questions from oncohemat and the remaining 4 to 5 questions from non-oncohemat, major chunk being from RBC disorders. You get 2 to 3 questions from RBC, one from bleeding disorders, and one from blood banking. This is how the hematology breakup is going. And lastly, of course, one of the most important topics, that is systemic pathology. I'm saying this as the most important because you will be able to take care of 10 to 12 questions of medicine also after doing pathology with me. So, systemic pathology, five main topics: GIT, lungs, liver, CVS, and kidney. We will be covering all this in our routine sessions one by one. This is what you have to know. With respect to oncohematology, now oncohematology is a topic that majority of the students tend to leave. Okay, sir, it's too tough, remembering the translocations, fusion transcripts, it's slightly on the tougher side. Absolutely no doubt about it. Let me just see. Okay, so with respect to oncohematology, the five must do main topics: acute leukemias, both ALL as well as AML, acute lymphoblastic leukemia and acute myeloid leukemia, ALL, AML; chronic leukemias, CML, chronic myeloid leukemia, and CLL, chronic lymphoblastic leukemia. The chronic leukemias, chronic lymphocytic leukemia, CML, CLL. Among the lymphomas, which is Hodgkin's lymphoma, much more important as compared to non-Hodgkin's. And last, I'll be glad if you tell me yes or no. Just a sec, let me put this on. Okay, it has started working. Perfect. So let us start with RBC disorders. We'll be starting with the basics of this. Now, firstly, the main topic in RBC disorders is anemias. So let us start with classification of anemia. Starting with the first point, that is classification of anemia on the basis of size of the cell. In our this session, which we will be making two main tables: classification on size and classification on etiology. Both these tables you had in the previous 1.5 year only, that is in the previous 3-4 sessions, you had 4 questions in FMG from these two tables. Classification on anemia on the basis of size of the cell. I can divide anemia into 3 types. Therefore, the size of the cell, it can either be a small sized RBC, that is, it can either be microcytic, hypochromic. Classification on the basis of size: microcytic, hypochromic. Next is normocytic, normochromic. Normocytic, and the last is macrocytic. Anemias. देखो, Starting with the first one, that is microcytic hypochromic. Now I can understand the word microcytic. Microcytic means the size of the RBC is small. What does hypochromic mean? Hypochromia. देखो बच्चे, normally RBCs have central one-third pallor. Normally RBCs have central one-third pallor. This is normal. All the RBCs, they have central one-third pallor. Next point, if the central pallor is more than one-third, it is called as hypochromic RBC. So this is what we mean by microcytic hypochromic. Microcytic size of the RBC is smaller. Hypochromia, central pallor is more than one-third. Next point, what are the causes of microcytic hypochromic RBCs? The most common cause of microcytic hypochromic RBC is iron deficiency anemia. Most common cause of IDA, most common cause of MCHC is IDA. That is iron deficiency anemia. Others are thalassemia, sideroblastic anemia. Next, sideroblastic anemia, and lastly, anemia of chronic disease. That is ACD, anemia of chronic disease. Therefore, some students tend to remember it as SITA, SITA, causes of MCHC, but these causes, they are written in the frequency in which they occur. Most common causes IDA, iron deficiency anemia. Others are thalassemia, sideroblastic anemia, and anemia of chronic disease. Next point. Let us have a look at two questions with this. Starting with the first one, have a look at this image. What do you see here? Firstly, bache, this is peripheral smear. How do we know this is peripheral smear? The RBCs are well spread apart. It is peripheral smear. Showing you diagnosis. Showing you, have a look at the RBCs. All the RBCs, they are of normal size and normal shape. Have a look at all the RBCs. They're normal size, normal shape, and they have central one-third pallor. This is a nice normal peripheral smear. Just to show you the normal size and shape of an RBC. देखो, पहले हमें normal पता होगा. We'll first know normal, then only we go to the diseases. Next, which is this cell? This is a lymphocyte. This is what lymphocytes look like. Next, what are these? These are the platelets. All these small ones, they are the platelets. So this is a nice normal peripheral smear. Next point. Now differentiate this from this slide. The minute I see this, what is the size of the RBC? Is it smaller than normal or larger than normal? It's a large RBC. Because this was normal, ये normal size था. As compared to normal, this is larger in size. These are macro-ovulocytes. They are large oval RBCs. All these, they are large oval RBCs. That is macro-ovulocytes, which is the characteristic RBC morphology of megaloblastic anemia. It is the characteristic RBC morphology of megaloblastic anemia, macro-ovulocytes. Next point. We'll come to the nitty-gritties of this slide when we'll be doing megaloblastic anemia in detail. Right now, we are just comparing the size of the RBCs. This was normal. These were macro-ovulocytes. Next, have a look at this. Now, the minute you see this slide, you are able to make out that this is a peripheral smear. RBCs are well spread apart. The cell in the center is a neutrophil. The examiner is pinpointing the neutrophil to you. What is wrong in this neutrophil? It has numerous lobes. How many? 1, 2, 3, 4, 5, 6. It is a neutrophil with 6 lobes. That is diagnosis, which is hypersegmented neutrophil. Diagnosis, hypersegmented neutrophil, which is the first feature of megaloblastic anemia. On peripheral smear. hypersegmented neutrophil. What do we mean by hypersegmented neutrophil? How many lobes of the neutrophil does it have? More than 5 lobes. More than 5 lobes in a single neutrophil. In a single neutrophil, or 5 lobes, or 5 lobes in 5% neutrophils. This is what we mean by hypersegmented neutrophil. More than 5 lobes means 6 or more in a single neutrophil, or 5 lobes in 5% neutrophils. Hypersegmented neutrophil. Next point. Now let's have a look at this slide. As compared to normal, this was normal. This was the normal size and shape of an RBC. As compared to normal, what is the size of the RBC here? The RBCs, they are much smaller. Hypochromia is more than 1/3. Images, they are all about comparison, and you very well know that in the FMGE exam also the images are being asked. So you have to know the images, absolutely no doubt about it. The size of the RBC is smaller, microcytic. Central pallor is more than 1/3. MCHC, hypochromic. Microcytic, hypochromic RBCs. And the most common cause of microcytic hypochromic RBC, most common cause being iron deficiency anemia. Most common cause being IDA, that is iron deficiency anemia. Next point. So continuing with the classification. Most common cause of MCHC was IDA. Next, now let me rephrase this question in another manner. What is the most common cause of anemia? What is the most common cause of anemia in hospitalized patients? Most common cause of anemia in hospitalized patients. In this, I cannot say it as IDA because iron deficiency anemia, we do not usually hospitalize the patient. The patient is treated on OPD basis. Most common cause of anemia in hospitalized patients, ACT, anemia of chronic disease, ACT. It is the chronic disease patients who are normally hospitalized. So hospitalized patients, ACT. Next point, most common type of anemia. Next point, most common type of anemia in ACT. Anemia of chronic disease, most commonly. I want you guys to tell me the answer to this. Most common type of anemia in ACT. Is it microcytic hypochromic, normocytic normochromic, or macrocytic? Which is normocytic normochromic. Most commonly, anemia of chronic disease, it is normocytic normochromic in nature, NCNC. Next point, we have written ACT, anemia of chronic disease, in microcytic hypochromic because rarely it causes MCHC also. Rarely it causes microcytic hypochromic also. But overall, the most common type of anemia in ACT is normocytic normochromic. Next point. This gets us to the other side, that is macrocytic anemias. Let us have a look at the more important point, macrocytic anemias. Which I can divide macrocytic anemias into two types, that is megaloblastic anemia, megaloblastic, and non-megaloblastic anemias. Megaloblastic and non-megaloblastic. First point, megaloblastic anemias, they are of course the folic acid and vitamin B12 deficiency. Megaloblastic anemias, they are folic acid and vitamin B12 deficiency versus non-megaloblastic anemias which are associated with liver diseases versus non-megaloblastic which are associated with liver diseases. So this is the classification of anemia on the basis of size of the cell. Microcytic normochromic, normocytic normochromic, and macrocytic. Next point. This gets us to our main classification, that is classification of anemia. This gets us to the main point, that is classification of anemia on the basis of etiology. Classification on the basis of cause of anemia, that is on the basis of etiology. I can divide anemia on the basis of cause again into three types, that is blood loss. The first cause of anemia is blood loss. Next, increased destruction of RBCs. बच्चे increased destruction of RBCs, it is called as hemolytic anemias. Increased destruction of RBCs, that is hemolytic anemias. And lastly, reduced production of RBCs. So, on the basis of etiology, anemia is classified into three types: blood loss, increased destruction, reduced production. First point, hemolytic anemias, that is increased destruction of RBCs, increased destruction, which is the most common RBC membrane defect. Let us have a look at, we'll just be classifying them today, but classification along with the inheritance, very important. Most common RBC membrane defect: hereditary spherocytosis, G6PD deficiency, sickle cell anemia and thalassemia. RBC membrane defect, बचे HS, hereditary spherocytosis. Most common RBC membrane defect, hereditary spherocytosis. Sometimes students go wrong and mark it as G6PD. No, that is the most common RBC enzyme deficiency. Most common RBC enzyme deficiency is G6PD, glucose 6-phosphate dehydrogenase. G6PD, glucose 6-phosphate dehydrogenase deficiency. Next are the hemoglobinopathies. Now, there are two main hemoglobinopathies. That is sickle cell anemia, which is written as HB small s. That is sickle cell anemia and thalassemia. Sickle cell anemia and thalassemia. Hemoglobinopathies. There are two hemoglobinopathies: sickle cell anemia and thalassemia. Next is PNH. Next cause of hemolytic anemia is PNH. That is paroxysmal nocturnal hemoglobinuria. PNH, paroxysmal nocturnal hemoglobinuria. The name tells you paroxysmal, intermittently, kabhi, nocturnal, at night, there is hemoglobinuria. PNH. And the last is AIHA. That is autoimmune hemolytic anemia. AIHA, that is autoimmune hemolytic anemia. Which these are the causes of hemolytic anemias. Now, last year December FMGE exam asked you the inheritance patterns. From this simple table, you had 2-3 questions. Starting with HS, hereditary spherocytosis, inheritance. There are 4 main Mendelian inheritance: autosomal recessive dominant, X-linked recessive dominant. You know this. HS, hereditary spherocytosis, autosomal dominant. Easy to remember. We write it as capital HS, hereditary spherocytosis, autosomal dominant. Next, G6PD deficiency. Please put a star. Very important. G6PD deficiency, which this is X-linked recessive. Next, both the hemoglobinopathies, sickle cell anemia as well as thalassemia, both the hemoglobinopathies, they are autosomal recessive. Again, easy. We write sickle cell as HB small s. Capital HS, hereditary spherocytosis, was autosomal dominant. HB small s, sickle cell anemia, is autosomal recessive. Next, PNH, paroxysmal nocturnal hemoglobinuria, and AIHA, they are acquired in nature. Therefore, we cannot blame our parents for everything. So, PNH and AIHA, they do not have a Mendelian inheritance. They are acquired in nature. These are the hemolytic anemias along with their inheritance pattern. So, increased destruction of RBCs, that was the second cause of anemia. And the last is reduced production of RBCs. Let us see this here only. Reduced production of RBCs means retic count is low, normal or high. What do we mean by retic count? Reticulocytes, which they are the immature RBCs seen in peripheral blood. What are reticulocytes? They are the immature RBCs. So they are the indicator of bone marrow erythropoiesis. More is the erythropoiesis in the bone marrow, more will be the retic count. So retic count is an indicator of bone marrow erythropoiesis. If the production of RBCs is reduced, retic count is low. If the production is reduced, retic count is low. Next point. Which are the diseases associated with a low retic count? Very, very important. First is aplastic anemia. First disease associated with low retic count is aplastic anemia. देखो बच्चे, easy. All the hematopoiesis takes place in the bone marrow. In aplastic anemia, all the lineages of the bone marrow are reduced. Therefore, there are 3 cells in peripheral blood: RBC, WBC, platelets. Where are they formed? In the bone marrow. So, bone marrow has 3 lineages: RBCs, erythroid lineage; WBCs, myeloid; platelets, megakaryocytic. Leave this, not interested at this point. All I am interested in is, in aplastic anemia, all the 3 lineages are reduced, so it has a low retic count. Next, which hormone is needed for erythropoiesis? Erythropoietin, secreted by kidney. So, chronic kidney disease. Next cause of low retic count, which is CKD, chronic kidney disease, CKD. Next is myelofibrosis. Next cause of low retic count is myelofibrosis. देखो, if the bone marrow is undergoing fibrosis, space for erythropoiesis is reduced. Bone marrow has limited space. अगर उसमें fibrosis हो गया, fibrosis has occurred, space for erythropoiesis is reduced, so it has a low retic count. Next, put a double star. Very, very important. Nutritional anemias. Both iron deficiency anemia as well as megaloblastic anemia. Nutritional anemias, they have a low retic count, very commonly asked. And the last is ACD. That is anemia of chronic disease. ACD, anemia of chronic disease. These are the diseases associated with anemia on the basis of etiology. Whatever we have written on this slide, which we will do this one by one. This is your topic, RBC disorders. So today what we saw was, we just made 2 basic tables: classification on size and classification of anemia on the basis of etiology, along with the fact that we had a look at microscopies associated with on the classification on size. Just as a quick recap for the students who joined later, this was a normal size and shape of an RBC. RBCs, they have a central one-third valve. Next, as compared to normal, these RBCs were much larger and they were oval in shape, macroveilocytes, which is the characteristic RBC morphology of megaloblastic anemia. Next, we had a look at hypersegmented neutrophil. This is a neutrophil with 6 lobes. What is a hypersegmented neutrophil? You have more than 5 lobes in a single neutrophil, or 5 lobes in 5% neutrophils. This is a hypersegmented neutrophil, which is the first feature of megaloblastic anemia on peripheral spleen. And lastly, we had a look at the RBCs, which was smaller than normal, that is microcytic, and central pallor is more than 1/3. Therefore, hemoglobin is present just at the periphery of the RBC. Rest everything is pallor only. Central pallor is more than 1/3. Hypochromic. Microcytic hypochromic RBCs. Most common cause of which is iron deficiency anemia. Most common cause is IDA. This was basics of the classification of anemias on the basis of size and etiology. Lastly, for those of you who will be giving the June FMGE exam, this is exclusively for the people or the students who will be giving the June FMGE 2021 exam, which is the FMGE target course. The last batch started on 4th January. So all the classes will be live. The previous 3 to 4 days of sessions which you have missed, you can see them on recorded session also. You have the best of the educators. I guess you know everybody. Razam, Dr. Naveen Purwal, Dr. Zainab, everybody you know us. So you can either contact me for the same or use the code Dr. Sushant for additional discounts. Lastly, and one of the most important points, consistency is important. So for the same, which is 60 minutes, 45 questions, we are launching Unacademy Combat. These are the best of the 45 questions. Do these. We will be giving you the explanations, the video explanations, as well as the written for same. Along with, of course, the best part being the top 100 students getting a prize and stuff. So the top 3 getting a pretty good prize. Do give this. You can unlock this is absolutely complimentary for everybody. You can which is simply unlock this and Unacademy Combat by the following code. The first set, that is from 5 to 6 p.m., it is on 10th January at 5 p.m. Done. Absolutely done. So as usual, and a pleasure to interact with everybody. You can contact me on Telegram for absolutely details. Done. Thank you and bestest of luck. Bestest of luck for the people. Take care.